Telemedicine OUD care has been highly successful at expanding access and improving quality of OUD care. Also, we've seen that improvement is as vulnerable as a person in early recovery from OUD, particularly in the face of hasty regulation. My ask is that in designing a permanent regulatory framework, we consider that we need it to work for the majority, not just for the more resourced and motivated minority. For patients, we should understand that any new barrier to patient access will discourage that access. In regulating a requirement for a patient, no matter how seemingly small, it should already be a universal component of good OUD care, or it becomes a barrier to good OUD care. A bona fide physical exam, whether in person or via telemedicine, does meet this standard, and so does maintaining a valid form of patient identification. An in-person requirement does not. For providers, those of us currently braving telemedicine OUD care are highly motivated and willing to accept risk and expense for public health and for the field. The majority of providers won't be as eager to sign up for new costs and risks unless there's an offsetting benefit. If special registration is the pathway chosen to enable telemedicine OUD care, it won't be successful if its net effect is a burden and an expense. My group would prefer for telemedicine OUD care to be enabled through regular rulemaking, as opposed to the addition of a new special registration process. However, special registration could potentially be a net benefit to multi-state telemedicine OUD practice if it offers a single national registration pathway, rather than state-by-state registration. For effective OUD care, it would only need to permit the prescribing of Schedule 3 through 5 medications that are FDA approved for the treatment of OUD, and presumably it would not authorize any on-site medication storage or dispensing. It would also be reasonable, as a condition of receiving special registration, to require attesting to certain practice elements that are established as universal in good quality telemedicine OUD care, such as PDMP reviews, a formal medication adherence support or diversion control policy, and a formal drug screen monitoring policy based on published standards of care endorsed by a reputable professional society. It would also be reasonable to require e-prescribing. I strongly discourage requiring any arbitrary dose, duration, or formulation requirements in any framework. Finally, I urge DEA to design any new process to improve your ability to oversee and audit prescribing patterns and to intervene when exploitative practice is identified, but to avoid attempting preemptively to control or limit clinical practice through regulation. It's been my pleasure to participate in this forum. Thank you for organizing this event and for this opportunity.